Can you just confirm that you can see the slides?
Yes, we can see the slides.
Okay. So good afternoon, everyone. It's a pleasure to speak to you today about heart failure. So just to understand what does heart failure meaning. So to understand this, you have to know that the heart is a pump, and each pump have a function. So it have to receive the fluid that it's conducting, and then eject this fluid to the target. So each pump has two functions. So first one is to receive the fluids, and then to pump these fluids. Okay. So when a pump fail, this means that the fluid will be collected before the pump, and sometimes it oozes outside, and there is no fluid or not enough fluid ejected to the target. So it's the same for the heart. If the heart is a pump and the heart fail, that means that the fluid, which is the blood, will be stagnate within the organ and increase the orthostatic pressure that cause oozes or osmosis of the fluids outside the capillaries toward the organs. This will be presented as congested neck vein and fluid collected within the lung causing lung edema or pleural edema, and fluid collected into the lower limb causing lower limb edema. And because the pump ejected from the blood is not enough, this will cause a low cardiac output symptoms in the form of dizziness and kidney injury. So this is an X-ray for a normal person. You can see that the heart size is normal and the lung field is clear. And here you can see that the heart size is enlarged in patients with heart failure, and there is marked congestion and upper lobe diversion. So by definition, heart failure is failure of the heart to receive, which is diastolic heart failure, or to pump blood, which is systolic heart failure. Because heart failure is the final destiny of any cardiovascular disease. It will present, as we mentioned, with low cardiac output symptoms in the form of dizziness, or back pressure in the form of dyspnea, lower limb edema, congested neck veins, bibasal crepitation and auscultation, and congested liver. So as we mentioned, heart failure is the final destiny of any cardiovascular disease can end up by causing heart failure. So basically, coronary artery disease like a myocardial infarction can end up by heart failure because of the muscle damage. Hypertension can cause heart failure because of the strain of the heart for a long time by the time the heart muscle will fail. Stenotic valve lesion like the aortic stenosis, mitral stenosis, long-standing arrhythmia because of the increased heart work. So any cardiovascular disease can end up by causing heart failure. Coming to assessment of patient heart failure, what are we looking for any patient suspected to have heart failure? In the history, we should ask about the shortness of breath, whether it's related to exertion, how far can the patient walk. This is very important for classification, severity of the disease, and to confirm the diagnosis, because as we will mention in few seconds, it's mainly a clinical diagnosis. Orthopnea, paroxysmal nocturnal dyspnea, how many times did the patient wake up at night because of shortness of breath. We will ask about history of the cause, as we mentioned before, like myocardial infarction, valvular heart disease, hypertension. Family history is very important for cardiomyopathies. In the examination, we are looking for the vital signs. So as we all know, vitals are vitals. So regarding the blood pressure, it will guide you about the management, how much can you give an ACE inhibitor or ARBs, and it will give you an idea about the cause. And the heart rate will guide again the diagnosis and management. We are looking also at the respiratory rate and oxygen saturation, which is a predictor of heart failure mortality. We are looking at the neck vein as a sign of heart failure. Lower limb edema. In the chest, we are looking particularly for bibasal crepitation, which is one of the signs of the heart failure. And on heart examination, we are looking for murmurs. As we mentioned, aortic valve stenosis or mitral stenosis can cause heart failure, or even the long-standing regurgitatory lesion. Investigation, we are doing an ECG to check the rhythm. So as we mentioned, tachyarrhythmia, especially AF with fast ventricular response, can precipitate or can worsen heart failure. We are looking for the rate because also tachycardia can worsen the symptom of heart failure. We are looking for the voltage as a predictor of pericardial disease. We are looking for QRS duration because this can affect the management, as we will mention later on. We are looking for LVH criteria to predict cardiomyopathies. On the chest X-ray, as we mentioned before, we are looking for cardiomegaly, pulmonary edema, upper lobe diversion. BMB as one of the markers of fluid overload. Echocardiogram or cardiac MRI to detect the heart function and systolic and diastolic function, and valvular heart disease as well. And of course, investigation of the cause. So coming to the diagnostic algorithm for heart failure, it starts with clinical suspicion of heart failure symptoms, and the next step will be requesting a BMB level. If the BMB level is normal, it's highly unlikely that this symptoms is because of heart failure or fluid overload. If the BMB is high, we will proceed with echocardiogram. Of course, here within the hospital, we are usually bypass this step and directly go with echocardiogram. After the echocardiogram, we will have a classification of the heart failure according to the ejection fraction. So we have heart failure with reduced ejection fraction less than 40%, or heart failure with preserved ejection fraction more than 50% and mid-range in between. And the most common question at this point is, we know about the heart failure with reduced ejection fraction, but how come patients who have normal ejection fraction present with heart failure? So this is an example of this. This is an echocardiogram for two different patients, both presented with heart failure symptoms. If you can see here, the heart function is very weak, and if we measure the volumes, the end diastolic volume here is 130 mils, and the end systolic volume is 100, which means that the ejection fraction is 23%, which is severely impaired. On the other side here, because of this is the patient with amyloid heart disease, because of the concentric LVH, the cavity within the LV is smaller than usual. So the end diastolic volume here is 50 and the end systolic volume is 20 with ejection fraction of 60. You can appreciate that the systolic function is completely normal in this patient. But if we come to assess what's the stroke volume in both cases. So stroke volume means the blood ejected in each cycle. So here, the end diastolic volume is 130 and the end systolic volume is 100, which means that the ejected blood is 130 minus 100 will be 30 mils. So the stroke volume here is 30 mils. The normal stroke volume is 50 to 100. So the stroke, the amount of the blood ejected is not enough. That's the systolic heart failure, and as well the heart will receive equivalent amount of blood, so it will receive only 30 for the next cycle, and that's what we call diastolic heart failure. So in this patient, he have combined systolic and diastolic heart failure. When we come to this patient, the end diastolic volume is 50 and the end systolic volume is 20, which means the stroke volume, which is the amount ejected, is 50 minus 20, which is, again, it's almost the same, 30 mils. So, which means the heart is ejecting 30 mils, not enough, and receive only as well 30 mils on the next cycle. So the blood will stagnate behind the heart. So in both situations, the cardiac output is not enough and the diastolic function is impaired. But here the ejection fraction is normal, and here the ejection fraction is reduced. So that's why I said in the beginning, the most important thing is the symptoms and signs, because it's mostly clinically diagnosis rather than, so of course the investigation is very important and it will help and guide the diagnosis, but it's mainly clinical diagnosis. So symptoms and signs, and then the number two is the ejection fraction, to classify this patient whether he have heart failure with reduced ejection fraction if the ejection fraction is less than 40%, or with preserved ejection fraction if the ejection fraction is more than 50%. But to diagnose, again, heart failure with preserved ejection fraction, you have to have raised natriuretic peptide and evidence of cardiac structural or functional abnormalities. Of course, as we can see in the last patient, there was LV hypertrophy, or increased left atrial size, or echocardiographic measurement suggesting impaired LV filling. When we come to management of a patient with heart failure with reduced ejection fraction, the first step is the medication or the medical treatment optimization. We start with ACE inhibitor, angiotensin receptor blocker or angiotensin receptor neprilysin inhibitor, which is the Entresto, sacubitril valsartan. Beta blockers, we all know that the patient with heart failure usually receive a combination of beta blocker and ACE inhibitor, either bisoprolol with ramipril or bisoprolol with Entresto. And mineralocorticoid antagonist, which is the eplerenone and spironolactone. And the newly introduced medication, the dapagliflozin and empagliflozin, and of course the diuretic furosemide. I would just like to highlight something about the beta blockers, because if you remember from the pharmacology study, that the first side effect of beta blockers is decreasing cardiac output and worsening heart failure. So we are still giving the beta blockers in treatment of heart failure, but we have to be cautious, because if you start a high dose in a decompensated patient, he may worsen the symptoms. So the precaution in beta blocker use in heart failure, so only for medication, only for beta blockers are allowed to use, which is the metoprolol, bisoprolol, carvedilol, and nebivolol. So we can't use propranolol or atenolol to control heart failure. Don't start the patient if the patient is decompensated. So you have to make sure that the patient is compensated and then start the beta blocker, because this may worsen the symptoms. Only start with a small dose and titrate up. So this is the three most important precautions in using beta blockers in heart failure. Regarding the optimization of medical treatment, we are aiming to reach a target dose and a target parameter. So we usually in patient admitted to the cardiology unit with a heart failure, we start small dose and start to titrate up, and we usually discharge the patient home once he's stable for follow-up either by the GB or heart failure nurses in the community to titrate up the medication. We are aiming a higher dose in this medication. I highlighted the most important medication that we are using, the ramipril. We are aiming 5 mg BD. The Entresto, we are aiming 97/103 mg BD. In bisoprolol, we are aiming 10 mg once daily. And in eplerenone, we are aiming 50 mg once daily. That's the target dose. So we titrate up this medication up to the maximum tolerated dose according to the following parameters. So for the beta blockers, we are looking for the heart rate. We are aiming heart rate less than 70. So 60 to 70 is a good number. Regarding the ACE inhibitor, ARNI, ARBs, and MRA and dapagliflozin, we are aiming blood pressure less than 140/90. With a stable GFR, with a potassium level between 3 and 5. We are also looking for a tight glycemic control with the hemoglobin A1C of less than 53 millimole or 7%. And we are aiming LDL less than 1.4. So after optimization of the medical treatment, if the patient is still symptomatic, we are going to go to the next step to consider a device therapy. If we go to this arm, if the patient have ejection fraction less than 35% and QRS duration more than 130, he could be a candidate for CRT device implantation. We all hear about the CRT, CRT-B, CRT-D. So what's the principle of CRT device? So the principle is this is a normal heart contraction. So if you can see the conduction coming from the SA node and to the AV node and then divided into left bundle and right bundle to stimulate both sides of the heart. So usually the LV activation coincide with the RV activation, both activated within almost the same time, causing a narrow QRS complex as a summation of both activation. But if we come to patient with bundle branch block, left bundle branch block, as in this demonstration, there is a delay in conduction on the left side. So it will cause activation of the left ventricle to be delayed than the RV activation, causing a summation of M-shaped white complex QRS. And that's the problem when there is a delay in contraction between the RV and the LV. If you can see here, the RV is contracting before the LV, that cause LV dysfunction, and this patient may present with heart failure. So the aim of CRT device, it's a device implanted under the skin with the 3 wires coming to the heart, one in the right atrium, one into the RV, and the third wire passing into the coronary sinus to stimulate the left ventricle. So it will detect the atrial activity and send the signal for both right ventricle and the left ventricle in the same time to synchronize the contraction of both ventricles. As you can see here, the contraction is more or less better than before. And this will implement it also in the ECG, because the QRS duration was here was maybe 190 for nearly 200. It will come down to 160, and this is one of the markers of successfulness of CRT implantation. If you come to the other arm here, if the QRS duration is less than 130, which means that the LV is contracting at the same time of the RV, there is no role of CRT in this patient, but we might consider this patient for ICD, because with this low ejection fraction, the heart is very liable for developing ventricular tachycardia or ventricular fibrillation. So simply it's a pacemaker implanted under the skin, the same principle as the CRT, but it's only come with 2 wires, 1 wire into the right atrium, 1 wire into the right ventricle, with a coil on the ventricular lead that detect the abnormal rhythm, as in this patient develop ventricular tachycardia, polymorphic ventricular tachycardia, and deliver a shock within appropriate time to restart the heart in the normal rhythm again. Patient education is very important, so we have to educate the patient how much fluid has to be given for him. We usually tend to do a fluid restriction for patient admitted to cardiology unit, less than 2 liters or 1.5 liter per day. But we have to also avoid dehydration. So we have to educate the patient how much have to drink every day, and to educate him about healthy diet, decrease the sodium intake into diet, about the alcohol intake, the immunization. You have to have flu immunization every year, quit smoking. Definitely the patient will ask about traveling and driving and sexual activity. So we have to educate the patient about everything after discharging him. Coming to the next topic, which is acute heart failure, patient presented with acute deterioration of heart failure. So management of this patient will depend on the perfusion, which is according to the blood pressure, whether the patient is in shock or not. So if the patient is not in shock, and presented with acute decompensated heart failure, we will start with loop diuretic immediately with a higher dose to relieve this congestion. But if the patient presents with cardiogenic shock, so decompensated heart failure with low blood pressure and hypoperfusion symptoms, so this patient will be transferred to ITU with the starting maybe of low-dose loop diuretic or immediate starting inotropes, a vasopressor, or consider LV assist device or intra-aortic balloon pump implantation. We have also to search for a cause. So patient presented with oxygen saturation less than 90% or respiratory failure will be a candidate for non-invasive or even invasive ventilation. For patient presented with life-threatening tachycardia, we should consider cardioversion. If the patient presented with life-threatening bradycardia, like complete heart block or 2-to-1 block or high-grade block, we will consider him for pacing, either temporary pacing or transcutaneous pacing, and then consider implantation of a permanent pacemaker later on. If the patient presented with STEMI, acute decompensated heart failure on top of STEMI, we're going to take this patient immediately to the cath lab to perform a primary BCI. Blood pressure less than 90 or shock emergency echo should be considered to exclude mechanical complication or severe aortic stenosis or pericardial tamponade. That's the end of this presentation, and I'm happy to receive any questions.